We start now the session of oncology, medical oncology. Now I have the pleasure to introduce Professor Dr. Iman Sharawi to give us a talk about can axillary staging for invasive breast cancer be done by ultrasound only.
Thank you very much, Professor Rida, for this introduction. The true title of this talk is Can Axillary كده سامعين؟ هو true title هو إن إحنا ممكن نعمل breast conservative surgery upfront breast conservative surgery without any axillary surgical interference ولا لا. هو ده الريل تايتل، بس طبعا لو إحنا كتبنا كده في الأول ممكن إحنا كلنا نتخض حتى إيه يعني حتى أول ما قرينا كان بالنسبة لنا ده shocking يعني. الأجندة النهاردة lessons learned from ECOSOC Z11 evidence to omit axillary surgical staging sound trial NSABP04 trial ENSIMA trial and our problem magnitude and the conclusion. طبعا كلنا عارفين ال axillary lymph node dissection and this was the standard method for determining axillary lymph node status until 1990. بس مشكلتها ان في upper arm lymphedema، في numbness or paresthesia، في shoulder movement restriction and في pain in the surgical area. Recently, sentinel lymph node biopsy became an alternative for axillary lymph node dissection. احنا طبعا restricting our talk to clinically negative axilla in the upfront setting. احنا ما بنتكلمش خالص على ال positive axillary lymph nodes، ما بنتكلمش خالص على ال axillary lymph nodes after neoadjuvant. That's outside the scope of this lecture. This lecture is concerned only with clinically negative axilla with upfront breast conservative surgery only. Lessons learned from ECOSOC Z11. Sentinel lymph node biopsy provided the same outcome as axillary lymph node dissection for patients undergoing upfront breast conserving surgery, adjuvant post-operative radiotherapy and systemic therapy. سواء with negative axillary lymph nodes اللي هو موضوعنا or even up to 2 involved sentinel nodes اللي هو مش موضوعنا. But it represented a milestone in surgical optimization. Optimization اللي احنا بنعمله دلوقتي لإما نعمل de-escalation سواء في السيرجري أو في الراديوثيرابي أو escalation العيانين اللي بيحتاجوا إن احنا نزود إيدنا شوية نتقل إيدنا شوية. فالزي 11 كانت أول واحدة أو أكتر واحدة كلنا عارفينها للدي escalation of surgery. لكن it raised two questions. أول question هو is it essential to perform surgical axillary staging أصلاً ولا لا؟ يبقى surgical procedure اللي بيتعمل مع ال upfront breast conserving surgery ده مش therapy. ده it's not for therapy. لأن radiotherapy can do the same. It's for staging and prognosis. So can we have to do it? Is it essential to do it? وممكن الالتراساوند second question can ultrasound replace surgery or not? Okay, يبقى ال Z11 raised these two questions. But ال ECOSOC Z11 كان فيها limitations. إيه limitations بقى؟ It is not known how much of the axilla was irradiated. Because there was no standardization of axillary radiation. يعني لو عايزين نعمل de-escalation للسيرجري لازم يبقى في standardization للراديوثيرابي. We do not know. We do not know العيانين دول أخدوا axillary radiation قد إيه. تاني حاجة كان في high incidence من protocol violations أو deviations فما نقدرش نحكم عليها. تالت حاجة كان في عيانين كتير أخدوا الهاي تنجل. الهاي تنجل هو including supraclavicular. طيب احنا عندنا evidence غير الزي 11 to omit axillary surgical staging. عندنا في 4 randomized control trials are going on. 2 published already و 2 lists are not published yet. الساوند والانسيما they are published. ودول randomized control trial. randomized control trial يعني معناها level 1 evidence. وعندنا 2 البوج والنوتيلس لسه they are not published yet. طيب ايه الساوند ترايل دي؟ الساوند ترايل was published في ديسمبر 23. دي non inferiority مش superiority. يعني مش بنقول ان الراديوثيرابي احسن من السنتينل ليمف نود، لا احنا بنقول السنتينل ليمف نود زيه زي الراديوثيرابي ولا لا. في فرق بين الاثنين خالص. This is a non inferiority randomized control trial. كانت على كام عيان؟ about 1400 patients. كانوا كلهم clinical T1 يعني احنا لو عايزين نعمل الدي اسكاليشن وما نعملش sentinel lymph node biopsy لازم التزم بان العيان يكون عندها اقل من 2 سم، اقل من ده according to the sound trial. تاني حاجه ان يكون clinically negative. clinically negative يعني by physical examination و imaging negative. الايمجينج الستاندرد هو الالتراساوند. تمام. These patients were randomized 1 to 1. لا اما ياخدوا sentinel lymph node biopsy يعملوها، لا اما ما نعملش حاجه خالص. ما نعملش حاجه خالص وندي راديوثيرابي طبعا. طيب ايه البيز لاين بيشنت اند تيومر كاركترستكس؟ اهم حاجه ان 82.5% يعني most of the patients aged more than 50 years. يبقى احنا ما عندناش داتا عن العيانين الصغيرين. يعني لو جات لنا عيانه عندها 40 سنه ما اقدرش اعمل لهاش sentinel lymph node biopsy. لازم العيانين اللي فوق 50 سنه بس. تمام. ادي اول حاجه. تاني حاجه الميديان سايز كان 1.1 سنتيمتر. احنا قلنا قبل كده انه لازم يبقى اقل من 2 سنتيمتر. يبقى الساوند ترايل لازم يكون العيانين فوق 50 years. تاني حاجه ان يكون 1.1 او اقل من 2 سنتيمتر. طيب العيانين اللي عملوا sentinel lymph node biopsy كان الديتكشن ريت بتاعتهم قد ايه؟ اللي هم حوالي 700 عيان. كان 13.7% positive axillary lymph nodes. منهم 0.6% كانوا اكتر من 4 positive lymph nodes. اكتر من 4 positive lymph nodes بالنسبه لنا احنا ريد فلاج، لان احنا هنعمل بقى سيستميك زياده وراديوثيرابي زياده وحاجات كده. فيبقى ال 13.7% positive axillary lymph node detection rate. هنشوف بقى 13.7% was translated into any favorable outcome ولا لا. العيانين كانوا estrogen receptor, most of them estrogen receptor positive, progesterone receptor positive. الساوند ترايل included اي عيانه اكتر من 1%. اكتر من 1%. يبقى عندنا الاستروجين لو ريسبتور بوزيتيف وير انكلودد، اللي هم في الاوريد ايه من 3 ل 5. يبقى من 3 ل 5 في الاوريد او اكتر من 1% في البرسنتج كانوا داخلين في الساوند ترايل ينطبق عليهم اللي هيمشي الكونكلوجن بتاعت الساوند ترايل. يعني مش محسوبين تريبل نيجاتيف، لان اوروبا بتحسب الاستروجين لو ريسبتور تبع التريبل نيجاتيف. الساوند ترايل حسبهم تبع البوزيتيف. طيب more than 87% were luminal in both groups. اللومينال هنا ما فرقوش luminal A و luminal B، كل اللومينال. يبقى most of the patients were luminal patients. الHER2 positive والتريبل نيجاتيف were underrepresented. يعني ما نقدرش نكسترابوليت الريزلتس اللي هتطلع دي في عيانين تريبل نيجاتيف ولا عيانين HER2 positive. اوكي؟ ليه؟ لأنه most of the patients were luminal patients. يبقى الساوند ترايل المين بوينتس الميديان ايج was 60 years، واحنا قلنا ان most of them were above 50. الادجuvant systemic therapy were similar in both arms. والpost operative radiotherapy was similar in both arms. لكن كان فيها حاجه 11% of both groups received partial breast irradiation مش external beam irradiation. about 5% received intraoperative partial breast irradiation اللي هو على هيئة intraoperative electron radiotherapy على هيئة boost. يبقى 15% received partial breast irradiation either totally or as a boost. تمام؟ مش كلهم خدوا external beam. البرايمري endpoint بتاعتهم كانت distant disease free survival. distant disease free survival of both arms were statistically insignificant. يبقى non-inferior. يعني لو ما عملتش sentinel lymph node biopsy زي عملتها. تمام؟ السكندري endpoint هي ال overall survival also was statistically insignificant. يبقى ال outcomes سواء عملت أو ما عملتش واحد. طيب الميديان فولو اب بتاعهم كان قد ايه؟ كان 5.7 years. الcumulative incidence of axillary recurrence was 0.4% in both groups. يبقى الاثنين زي بعض، حتى الاxillary recurrences كانوا the same in both arms. يبقى conclusion of sound trial: the 13.7% detection rate of sentinel lymph node biopsy group was not translated into improvement of distant disease-free survival or overall survival. The omission of surgical axillary staging is non-inferior to sentinel lymph node biopsy. لمين بقى؟ for postmenopausal اللي هم اكتر من 50 patients with clinically negative وimaging negative T1 invasive breast cancer undergoing upfront breast conserving surgery and post-operative radiotherapy. تمام؟ طيب في ترايل قديمة بقى وغريبة جدا ال NSABP04 ترايل. الترايل دي اتنشرت 2002 وكانت discuss 25 year follow up of patients. كانت randomized trial جزء منها خدوا الكلينيكال نيجاتيف lymph nodes patients with clinical negative axillary lymph nodes. كانت بتقارن بين الراديكال ماستكتومي at that time was standard والتوتال ماستكتومي alone والتوتال ماستكتومي followed by irradiation. يعني في two groups ما عملوش أي axillary surgical interference. كانوا حوالي 1000 عيانة كلينيكالي نيجاتيف أكزيلا بين الراديكال ماستكتومي زي ما قلنا وبين التوتال ماستكتومي ومفيش أكزيلي دايسكشن واتسو ايفر ومعاها راديوثيرابي والتوتال ماستكتومي ألون. العيانين كلهم ما خدوش ادجوانت سيستم لانها دي اتنشرت 2002 وكانت 25 سنه فولو اب 25 سنه فولو اب. وكان ال 70% of patients الجروب كان 50 years of age or older طبعا والدايمتر كان 3 سم 3.3. الديستنت disease free survival was statistically insignificant بين الثلاثه جروبس. يبقى distant disease free survival سواء عملت اي auxiliary surgical intervention او ما عملتش خالص هو زي بعض. الاوفر survival للكلينيكالي نيجاتيف احنا بنتكلم على كلينيكالي نيجاتيف برضه was statistically insignificant بعد 25 سنه. امال ايه اللي فرق؟ اللي فرق اللوكال او regional recurrence in this trial. يبقى at 3 وat 5 وat 10 at 25 years الديزيز فري سرفايفل ما فرقش، الديستنت ديزيز فري سرفايفل ما فرقش، الاوفرول سرفايفل ما فرقش، لكن اللوكال ريجنال ريكارنس هو اللي فرق في الكلينيكال نود نيجاتيف. الراديكال ماستكتومي اللي احنا بنعمل فيها اكسيلري دايسكشن كان 9%، التوتال ماستكتومي الون كان 13%، والتوتال ماستكتومي بلس راديوثيرابي كان 5%. طبعا مش دي اللي احنا بنغير البراكتس عليها، لكن احنا بنشوف ان احنا من 2002 و25 سنه كان this was true. ايه البراكتس تشينجينج ترايل ثانيه اللي زي الساوند ترايل؟ الانسيما ترايل. الانسيما ترايل دي published ديسمبر 2024 كانت برضه non inferiority randomized control trial about 5000 عيان. زودوا شويه التي بدل كلينيكال تي 1 الون بقى كلينيكال تي 1 and تي 2 and still negative axilla clinically and imaging. imaging we mean ultrasound. والscheduled طبعا for upfront breast conserving surgery. They were randomized 4-1. 4 هو sentinel lymph node biopsy وال1 هو axillary surgical omission. بعد كده sentinel lymph node biopsy والري randomized. It's not published yet. لكن احنا we are concerned لحد ان احنا بنقسم العيانين ل sentinel lymph node biopsy versus axillary surgery omission. ال patient characteristics ال tumor size كان determined by ultrasound. لو انا ما عرفتش اعمله by ultrasound بعمل بموجرام وبعدين ال MRI in that order. Most of the patients برضو كانوا اكتر من 50 سنة. ال median tumor size كان 1.1 سنتيمتر بالضبط زي الساوند. ال ER وال PR most patients كانوا positive. ال HER2 most patients were negative. والترايل دي كانت اللي بيعتبروا ال ER negative وال PR positive are considered positive. يبقى they were included in the ENSEMA trial عشان احنا ساعات بنقابل ال ER negative وال PR positive وما بنبقاش عارفين هنعمل فيهم ايه. دول دخلوا في الانسيما trial as positive. طيب 94% were luminal. يبقى دايما الساوند واللومينال والدي اسكاليشن في العينين اللومينال مش في التريبل نيجاتيف ولا الهير 2 بوزيتيف. ما عندناش ايفيدنس بكده. الديتكشن ريت بقى بتاع سنتينل ليمف نود الليمف نودز في الجروب اللي هو سنتينل ليمف نود بايوبسي كانوا كان 15% بوزيتيف اكسيلري ليمف نودز. الميزه في الانسيما ترايل انه عملوا راديوثيرابي كواليتي اشورنس. طبعا انا استاذنا الدكتور حسن خالد هيتكلم عن الراديوثيرابي بالتفصيل، لكن بس انا يعني بنبه على انه العيانين كلهم كانوا سباين بوزيشن، كان سي تي ديلينيشن، كان 3 دي او اي ام ار تي، وما كان partial breast irradiation not allowed، والسيملتينيوس انتجريتد بوث برضه not allowed في العيانين اللي هياخدوا هايبوفراكشنيشن. واهم حاجه انه الديلينيشن كان according to الارتوري مش الاسترو، لانه مختلف. الاكسيلري ديلينيشن الار تي او جي مختلف عن الاسترو. الفاكتور الوحيد اللي لقوه مهم او significant في العيانين في الاكسيلري دوز ديستريبيوشن كان البادي ماس اندكس. العيانين اللي اكتر من 30 الفوليوم بتاع الاكسيلري amount of radiation to the axilla كان اكتر في ليفل 1 وليفل 3 والدوز، الفوليوم والدوز. البرايمري اند بوينت كان الانفيزيف ديزيز فري سرفايفل مش الديستنس. at 5 years they were insignificant, statistically insignificant between the surgical omission group والsentinel lymph node biopsy, the conclusion was they were non-inferior. Overall survival it was a secondary endpoint and it was statistically insignificant. أنا خلصت. After a median of follow-up 6 years كان الاكسيلري ريكارنس اكتر في الجروب اللي هو كان فيه سيرجيكال اوميشن. كان الفرق بينهم في الناس اللي عملوا سيرجري كانوا 10 عيانين، الناس اللي ما عملوش سيرجري 12 عيان. فطبعا ده يعني عدد العيانين اصلا قليل. ده الميديان فول اب بتاعه كان 6 years. السب جروب اناليسيس قالت ان كل العيانين استفادوا لما في السيرجيكال اوميشن ما عدا الجريد 3. العيانين اللي عندهم جريد 3 ما استفادوش. وحاجه كمان يعني I don't find an explanation for it، العيانين اللي هم اقل من 1 سم. فديفنتلي من 2 ل 3 هم احسن في السيرجيكال اوميشن. اقل من 1 السب جروب اناليسيس كده. We don't change our practice according to subgroup analysis. Subgroup analysis is for another research. البيشنت reported outcomes and safety كل البارامترز بتاعت البيشنت reported outcomes were better في العيانين اللي عندهم surgical omission breast والarm. يعني 15% detection rate of sentinel lymph node biopsy group was not translated into improvement of invasive disease-free survival or overall survival. The omission of surgical axillary staging is not inferior to sentinel lymph node biopsy for post لمين بقى؟ post menopausal with clinically negative axillary lymph node imaging negative T1 or T2 لكن أقل من 3 سم. محدش دخل وعنده 4.5 سم. الجايد لاينز بقى طيب بتقول ايه؟ الجايد لاينز الاسكو والكانسر كير اونتاريو اللي بيقولوا ان العيانين اللي اكتر من 70 سنه كلينيكلي نيجاتيف ليمف نودز وهرمون يعني لومينال دول السنترال ليمف نود بايوبسي از نوت ريكوايرد. الانسيسيان بقى واسع جدا واحنا ما بنمشيش عليه ومش هنقدر نمشي عليه without trial without clinical trial. ليه؟ لانه قايل either or كاتب فوق ان clinical T1 to T3 without molecular subtyping. فانا مش هنقدر احنا في عينه T3 نعمل لها upfront surgery مش ممكن. ومش ممكن T2 وهير 2 بوزيتيف او تريبل نيجاتيف وبرضه مش هنعمل لها نيو ادجمنت. فاحنا NCCN جايد لاين الايذر اور از نوت يعني meticulous او is not sound. يعني البروبلم ماجنتيود بقى بتاع اللي احنا بنقوله ده ايه؟ Globally, an estimated 2.3 million women were diagnosed with breast cancer in 2022. By 2050, new cases will increase by 38% globally. Postmenopausal women with early luminal breast cancer اللي هم هنتكلم عليهم دول ربع العيانين. احنا بنتكلم على نص مليون عيانة. طيب في مصر بقى ايه اخبارنا؟ النمبر اوف نيو كيسز 150,000 كل سنة. البريست 34% of them يعني حوالي 35% من 150,000 احنا. طبعا ده ميل وفيميل، احنا بنتكلم على الفيميل بس. طيب احنا متوقع 2050 هنزيد. طبعا هنزيد في الانسيدنس وفي المورتاليتي. طب هنزيد ال 38% بتاعت العالم؟ لا، هنزيد 78%. هنزيد 78%. فالبروبلم دي يعني we should agree on a consensus what to do. الماركت انكريز اولا الاويرنس والسكرينينج وان احنا العيانين بدل ما كانوا ستيج 4 وبيموتوا بقى هيجوا ايرلي ستيج وهيعيشوا. البريزيدنشال انيشيتيف هنقابل عيانين بدري فهيعيشوا اكتر. الديتكشن ريت اكتر. احنا الاول ما كنا بنقابل العيانين الستيج 3، دلوقتي تبع المبادره بقت ستيج 2، فالعيانين دول هيعيشوا اكتر والعيانين هنديتكشن ريت اكتر لان دخلنا السونوموجرام. نتيجه الاكسيلري سيرجيكال اومنيشن فور كلينيكال نيجاتيف نود احنا كنا بادينهم باكتر من 70 سنه ولومينال وكلينيكال تي 1، وبعدين بقينا اكتر. الساوند ترايل قالت اكتر من 60 سنه ولومينال وكلينيكال تي 1، وبعدين الانسما ترايل اكتر من 50 سنه ولومينال واقل من تي 3 من 3 سنتيمتر اسفل من 3 سنتيمتر. طيب we need the consensus about what we're going to do. أول حاجة generalizability of the results. الانسما والساوند Egyptian patients were not represented. الانسما كانوا 150 سنتر بس كلهم في ألمانيا. الساوند كانت في إيطاليا وتشيلي وإسبانيا وكده، فما فيش مصريين. فإحنا قبل ما generalize the results لازم نقرر هو إحنا هنمشي على كده ولا محتاجين نعمل ترايل إحنا بقى على عيانينا الأوبيز. تاني حاجة ال reproducible and validated categorization of cancer as imaging and zero. الكورتيكال thickness كام؟ الانسما اعتبرت أي حد الكورتيكال thickness أكتر من 2.5 إن هو ده يعني suspicious of malignancy ولازم ناخد منه biopsy. فإحنا النيجاتيف أقل من 2.5 كورتيكال thickness. فهل في مصر هنعتبر برضو 2.5 ولا إيه؟ لأن هو globally مفيش cut off. We don't have a cut off. longer follow-up are needed for these low-risk population definitely لأن دول by definition are low risk. فالريلابس هيجي بعد 5 سنين مش قبل 5 سنين، بعد 5 سنين. بس احنا شفنا ال NSABP له 25 سنة العيانين كويسين. البوست اوبريتيف راديوثيرابي كواليتي اشورنس احنا استاذنا بقى الدكتور حسن هيقول احنا نقدر نمشي على الاسترو كمان ولا لازم نلتزم بالار تي او جي والبي ام بودي ماس اندكس لازم يبقى ان كونسيدريشن تيكن ان كونسيدريشن والافيلبل ريسورسز.
طبعا اكيد في اسئله كتير، بس هو انا ماي كومنتس على طبعا الاستاديز دي رائعه جدا في حته ان احنا بندي اسكاليت المانجمنت. لكن البرايمري اند بوينت كان دايما الاوفر سرفايفل والديستنت ميتاستاسيس سرفايفل which is the most important طبعا في الانكولوجي عموما. لكن احنا من الاكسبيرينس بتاعتنا الناس دول مشكلتهم دايما ايه؟ لما نرجع للي بيحصل معانا والقديم، مشكلتهم في اللوكال، حتى اللوكال ريكرنس او اللوكال ريجنال ريكرنس لو ما اثرش على السرفايفل لكن بيمباكت جدا على الكواليتي اوف لايف. ماي كومنت ان هو هنا حط اللوكال ريكرنس وقال 0.4%، لكن مش البرايمري اند بوينت عنده حتى ولا سكندري اند بوينت. بمعنى انا اسف اخر حاجه ان السرفايفل ما فرقش او نون انفيرور رايت. وكلنا بالنسبه لنا كونجست او شغالين في مجال الانكولوجي الاوفر اول سرفايفل يهمنا جدا جدا جدا. لكن اذا بصينا رقم 2 للكواليتي اوف لايف كان نفسنا تبقى الداتا دي موجوده كمان تسبورت حته الكواليتي اوف لايف كلوكال ريجنال كنترول. التو جروبس اخبارهم ايه مع بعض؟
الفكره اللوكريشن بتاعت زمان ما كانش بيتعالج راديكال انسان. دلوقتي العيانه لو جالها ايزوليتد لوكريجنال ميكانيزم بتتعالج بايزوليتد بتتعالج راديكال انسان، دخلها اكسيلري دايسكشن خلاص ما بقتش مشكله زي كده.
إيمان برضه أنا عندي كنت طبعا thank you very much for the presentation. بس إحنا برضه عندنا مشكلة، هم حتى الناس الحاجات اللي هم اللو ريسك دول بيقدروا يعملوا لهم أونكوتايب، بيقدروا يدوا adjuvant treatment depending على الأونكوتايب. إحنا مشكلة ما عندناش
إن إحنا we cannot jump
لأن
jump into
يعني
without إن كل الكونتكست يبقى موجود. لا لا ما كانوش عاملين لانهم مش واخدين البوزيتيف لينف نود اصلا. هم واخدين كلينيكالي نيجاتيف لينف نود، واخدين كلينيكالي نيجاتيف لينف نود، وكل العيانين اللي انرول اقل من 3 خط، اقل من 3 خط.
هو احنا طبعا عندنا اسئله كتير جدا، لكن الدكتور ده بيقول لي عشان الوقت. شكرا دكتور ايمان. ثانك يو فيري ماتش. And now for the second presentation, it's my honor to introduce Professor Dr. Hassan Khalid, Professor of Clinical Oncology at Al-Azhar University, and he is going to talk us about the controversies in the axillary node irradiation in the operable breast cancer. تفضل.
My colleagues and friends, Department of Clinical Oncology at Shams University, with this session among the positive faculty meeting. I like to thank Dr. Bilal for the talk. She covered most of the items. I'll try just to concentrate on the radiation therapy. So I will be talking about the controversies in axillary node irradiation in operable breast cancer. Well, management of the axilla in patients with early breast cancer has undergone major change in the last few years due to the multimodality approaches and the declining value of axillary surgery as a therapeutic and staging procedure. As far as when the central lymph node had become a standard of care in patients with node-negative breast cancer, and with the evolution of the molecular classification of breast cancer, both the therapeutic and the staging of the axillary lymph node dissection and its data we can collect from it became a bit underpowered. Also, with the ongoing trials and the trial being published concerning the central lymph node dissection, especially the Enzima trial, SOUND trial, the ACOSOC trial, and the AMAROS trial has also challenged the therapeutic impact of axillary lymph node dissection. We all know these are the drawbacks when doing axillary dissection, which could be lymphedema, joint shoulder immobilities, and neuropathies. But still, axillary lymph node dissection is the standard of care for patients with clinically node-negative breast cancer with positive central lymph nodes who do not meet the eligibility criteria with the above-mentioned trials, also in cases having node-positive breast cancer in the upfront surgery, and in cases with residual nodal disease after primary systemic treatment. There have been a lot of progress in the domain of radiation therapy in the last 2 decades. Now we are having many types of machines. We are having now extrapolating the data of the patient from CT scans, MRI, combination of both, even PET-CT. But still, the weak point in the techniques of radiation therapy is the delineation or the defining of the nodal target volumes to be irradiated. In order to minimize this uncertainty, we are having in our hands 2 ways of guidelines, which are the RTOG Atlas and the ISTRO guidelines, which is most of us use either this or that. The aim of this talk will review the available data on modern axillary management in breast cancer with focus on the target volume delineation of axillary nodes according to either ISTRO and RTOG. I would like to remind you that most of the trials that we are going to discuss as different techniques of radiation oncology. A good part of these trials executed the radiation therapy during the 2D era, when you are using only 2 dimensions radiation therapy, and also different radiation doses. This will appear in the coming trials. First of all, I'm going to present the ORTC trial that confirmed the importance of hormonal treatment of breast cancer, either by mastectomy or conservative surgery with axillary node dissection followed by radiation therapy in cases having heavy nodal infiltration or high-risk cases for axillary affection. This ERDC trial have concluded patients, thousands of cases that have been randomized to either receive regional nodal irradiation or not. And it has been found that adding radiation therapy for heavy nodes and those with high risk of disease would add to the disease-free survival and local control. As we see here, this is the technique where we are lying at that time on the bony landmarks because it was a 2D, and we find it's quite different than the other trials. Usually use two portals, anterior and posterior, with different. Usually the fractionation used as 2 grays for 50 grays. Another trial, the MA20, having the same idea. We're going to irradiate post-operatively patients with node positive on the high risk, and also it had reached the same outcome. This is the technique, which is quite based on 2D also. Then coming to this Amorous trial, where the axillary lymph node dissection was challenged against axillary radiation therapy in early cases with T1 and T2 disease and without palpable axillary lymph nodes. This is the study design. Most of the cases have been subject to sentinel lymph nodes that showed to be positive. All the 3 levels of the axilla were irradiated. Also, it was a kind of 2D irradiation therapy based on the bony landmarks. And they used 2 parallel opposing fields, and usually the posterior field has been reduced to the medial side to avoid radiation to the lungs. And we can see here that the disease-free survival and overall survival between the 2 groups were comparable. Strangely enough, the lymphedema was significantly lower when we are using radiation therapy rather than axillary lymph node dissection. The treatment outcome has been extended for 5 years and even for 10 years, it's the same. So here, the Amorous trial would tell us that for this type of early disease, radiation therapy to the axilla is comparable with axillary lymph node dissection, even with less lymphedema. Then coming to AquaZoc trial, that include also early disease with T1 and T2 and 0 disease and sentinel lymph node metastasis. And in this trial, the axillary lymph node dissection was challenged with against no treatment to the axilla. So we are having clinical cases T1 and T2 and 0 lumpectomy and sentinel lymph node dissection. Sentinel lymph nodes were positive. They are randomized to axillary lymph node dissection versus no dedicated treatment to the axilla, and the patient received whole breast irradiation with adjuvant systemic therapy, then followed. And we can see here that the local regional recurrence is comparable in both treatment arms. And we have a comment here on the technique of the radiation, where a considerable part of this type of radiation that has been offered to the patients have been using high tangential fields. It's a type of field that's extending up to the level of the humerus. So it would cover a good part of level 1 and level 2 of the axilla. We know that level 1, at least 70% of the metastasis occurs in level 1. And it has been found that the dose distribution to the lymph nodes at level 1 and 2 was compared to the Amorous trial that proved in this situation that radiation therapy is equivalent to axillary lymph node dissection. So it seems that the unintended irradiation to the axilla has accounted for this good results. Then coming to Sound trial, where the data extrapolated from the sentinel lymph node had been challenged against ultrasonography, has been presented by Professor Iman. It has around 700 cases in each arm. And as Professor Iman has concluded that the treatment outcome was comparable as far as disease-free survival and overall survival. Then coming to another trial, which is the Enzima trial, that having the same objective, treating patients with T1 and T2 disease and zero clinically and zero. And they have compared the omission of axillary lymph node dissection. And they have randomized the patients in this trial design. And patients that had central lymph node that have been subjected, the group that have been subjected to central lymph node dissection had been that showed to be positive metastasis. They had randomized to either follow-up or axillary lymph node dissection. So a group of patients that have showed central lymph node positive in this trial had been exposed to axillary lymph node dissection, and the cases that had shown heavy nodal infiltration received radiation therapy dedicated to the axilla. And this is the outcome. This free survival and overall survival were comparable. Then we are going now to go deep a bit in the technique of radiation therapy, as there was something like 276 cases have been taken as a sample, and the radiation therapy technique had been studied. And as I've said, the radiation therapy was concluded to the breast only, and they used a modern type of radiation therapy where the data has been extrapolated from CT scans. And most of the cases were treated by 3D conformal radiation therapy, and other cases were treated with intensity modulated radiation therapy. They have received hypofractionated radiation therapy, and boost was allowed. Also in this trial, with the axillary lymph nodes level 1 to 3 had been contoured using the RTOG technique. As we can see here, in the cut in A, it is level 1, B is level 2, and C is level 3 of the axilla. And those volume histograms were drawn, hotspots were located, and here the use of high tangentials or comprehensive nodal irradiation was not allowed, as I have mentioned. But we can find that with irradiating the axilla, even with this modern technique that we usually use in most of our departments, we can find that 25% of the cases had received 95% to the prescribed breast dose of radiation to axillary level 1, and approximately 50% of the cases were irradiated with a median radiation dose of more than 85% to level 1. As we can see here, the last row, column 4, under the axillary level, the median is 85.4. But the radiation dose to the axilla level 2 and 3 were significantly less compared with level 1, but still 25% of cases had received 75% of the prescribed dose to axillary level 2, as we can see here. So, unintentionally, even with using modern technique of radiation therapy, still a good part or a considerable part of the axillary node had received radiation therapy. And this maybe can move this from unintended radiation to even intended radiation in the liver. Coming to the second part of my talk, which is going now to discuss the RTOG Atlas versus the ISTRO guidelines. Both guidelines are quite good and effective. Most of us, I usually use the RTOG, and here is the data concerning how to localize the axilla with its different levels, the RTOG. The ISTRO is more sophisticated, as you can see. But we found that from studies done on using CT scans and PET CT imaging, found that not all the axillary lymph nodes would be affected by the metastasis from the breast, but rather a group of lymph nodes likely in level 1 at the dorsolateral to the pectoralis minor and 1 to 3 centimeters below the subclavian vein, and levels 2 and 3 accumulated in the vicinity of the subclavian vein. As we can see here here's a healthy lymph nodes on one side, and the pathologically or the potentially affected lymph nodes on the other side. And I think it's much less compared with the healthy nodes. And when comparing the studies done on the axillary lymph nodes with PET-CT scan between the RTOG and HISTRO guidelines, we find that both uh, guidelines have covered efficiently the potentially lymph nodes to be affected by the metastasis. Some trials would claim that the HISTRO may be having a better covering and delineation of these nodes. But most of the studies suggested to be that both guidelines are equivalent. But on the other hand, the Estro CTV, if you are using the Estro, will get much of the healthy nodes outside the delineation. We can find something like 60% of the nodes, of the healthy nodes, would be excluded. On the other hand, the RTOG would encompass a significantly higher proportion of healthy lymph nodes. As we can see here, level 1, level 2, and level 3. And this cut, we can find the difference. On the right-hand side, we can find the RTOG, and the left side, we can find the Estro. Coming to the last point, if we are going to treat patients with primary systemic treatment, usually we use it whenever we are having locally advanced inoperable or large tumor and we want to do conservative surgery with better osmosis, or in cases which are non-luminal, where there will be an impact on the survival of the patients. Here, the optimal axillary management and role of axillary ablation in early breast cancer patients receiving primary systemic treatment still remains clear. Usually, patients having initially node, axillary node, negative axillary node with negative central lymph node, and after primary systemic treatment, they will not require axillary treatment. But the problem comes with cases that having positive nodes prior to primary systemic treatment, and after this treatment, they yielded sentinel nodes of YPN0. Here there's kind of controversy in treatment of these cases, but in good retrospective studies in the UK, having a large number of cases, explored the role of regional nodal irradiation in this type of patients, T1 and T2, 3, and positive after primary systemic treatment, and they found no benefit of survival from adding regional nodal irradiation to whole breast radiation therapy for YPN0 or YPN positive patients. And it seems also that in this series of cases, the axilla level 1 and 2 had been covered efficiently with radiation therapy. This diagram can summarize my talk. Finally, I conclude that recently, in view of disease molecular classification, sentinel lymph node biopsy, and primary systemic treatment, the therapeutic and the value of axillary lymph node dissection as staging procedure is underpowered. Still, axillary lymph node is indicated. Axillary lymph node dissection is indicated in clinically not positive and adjuvant RT in heavy nodal affection. According to Amaru's trial, axillary irradiation is efficient as axillary lymph node dissection in early disease. Also in postmenopausals with clinical T1, maybe T2, and node negative, likely with luminal disease, can be treated with lumpectomy and breast irradiation. The tangential fields used to treat the breast usually includes considerable part of level 1 and 2 of axillary lymph nodes, even when using 3D conformal radiation therapy and IMRT. Thus, radiation therapy contributes to the axillary local control. The challenge in irradiating the axilla is to spare healthy axillary nodes to reduce the potential morbidities. It seems HISTRO guidelines is superior to RTOG Atlas in this issue. Thank you.
Thank you, Dr. Hassan, for the excellent presentation. And now we have only one question for, yes, Dr. Iman.
Thank you very much.
Next talk will be about dilemma of auxiliary management in modern breast surgery, presented by Professor Dr. Ahmed Gamal.
السلام عليكم. انا المحاضره كلها النهارده عن المانجمنت واكسبت، فانا ما اعتقدش ان انا اكيد مش هضيف جديد على كل الاساتذه قالوا. انا هختصر الموضوع وهقول وجهه نظر الجراحين اللي هي ما بتبقاش اندبس قوي زي دكاتره الاورام، باشمهندس براينز، حاجه رهيبه كلكم حافظينها، احنا اقل من كده بكتير. وهقول في الاخر اخر كام سلايدز احنا بنعمل ايه. لو الاكشوال وورك في الريال لايف عندنا مش سلايدز موجوده تاني. هو ما بيقلقش. اول حاجه طبعا اكزيلري سيرجي ثيرابيوتيك اور دايجنوستيك بروجنوستيك. انا سؤال كده يا جماعه مجرد بعمل يعني شغل هنا شوف. اول حاجه في بايس. I declare I believe in axillary surgery in 2025 is a prognostic and will be gradually replaced by biologic and genomic markers. So axillary surgery is less relevant to breast cancer treatment. I am with the escalation of axillary surgery. That's declaration. Starting from early 19th, axillary dissection was performed as a radical mastectomy by Halstead, going to central nodes biopsy in early 2000, and I don't know when, but it will. No nodal surgery at all. 20, which time I don't know, but it will be happen that there will be no surgery in the axilla. Looking back over history from 460 BC, Galen postulated a humoral theory conceived by Hippocratic that's belief in what's called the black bile. Black bile, which is systemic disease of cancer. The cancer is not localized, it is systemic. That's the first postulation was by Hippocrates. And Galen, he said that there is a black bile in the blood and the cancer is coagulum in special places. Looking back in 1757, French physician Henry F. Laudran was the one who first surgeon to support the concept of axillary dissection as an integral part of surgical treatment of breast cancer. 1866, Virchow published textbook Cellular Pathology, which he reported the result of his autopsy. Virchow observed that women who died of metastatic breast cancer generally harbored metastasis in the axillary node at the time of death. He postulated that the axillary lymph node served as a nidus of the distant spread of breast cancer. Virchow Halstead hypothesis that the axillary lymph node is a nidus and we shall excise the whole breast with the nodes in order to decrease the burden of the cancer. That was in the late 18,000s and it's continued for 70 years. Lymphatic function. The lymphatic system returns protein, lipids, water from interstitial space to the intervascular space. Lymph node received only a fraction of apparent lymphatic flow. Rest shunt into venous system via lymph vascular shunt. Lymph node metastases. Lymph node are not necessary for generation of lethal distant disease. Axillary lymph node are in vivo biological marker to assess the circulation, although imperfect. Lymph node are not a barrier to metastasis. Morbidity. Of course, we all see the morbidity of axillary lymph node dissection starting from pain, numbness, paresthesia, degree of restriction of arm mobility, dissatisfaction of the appearance of axillary scar, some degree of arm swelling, lymphedema, and infection. Lymphedema, how we measure lymphedema? We have several measures to measure lymphedema. The most common used is the 4 points circumference of the arm and compared to the other arm. Less invasive nodal intervention equal-less lymphedema. And it's obvious from the graph, radical mastectomy 60% lymphedema, and no nodal surgery equals 0% lymphedema. The isolation of breast surgery and premises بتاعتنا. Biology is the main key and more powerful predictor than anatomic stage. Breast cancer is a systemic disease. Lymph nodes are prognostic indicator of cancer, not barriers. Axillary surgery provides very little survival advantage. Systemic therapy and radiation therapy contribute to local and regional control. It de-escalation examples, mastectomy to breast conservation, neoadjuvant chemotherapy conversion to breast conservation, oncoplastic techniques, 5 to 10 milli margins into no ancient tumor. That's de-escalation, decrease amount of excision, slow steady decrease in extent of nodal surgery. Of course, Halsted, the father of modern American surgery, he performs the Halsted radical mastectomy, removal of breast tissue and skin, full axillary node dissection level 3, remove pectoralis major and minor, required skin graft, or healing by secondary intention, disfiguring, disabling chronic veins. That's its main morbidity. And it's obvious from these images, even this female tend to bend its shoulder in front to decrease the cosmetic disfigurement to happen to her. Series of classic randomized perspectives. These trials and many more led to incremental de-escalation of breast surgery. Not a complete list, the coming list, not a complete list, just to present some trials. Red box indicate prospective and randomized clinical trials. NSAP created in 1970 a debate. NSAP is the first, which launched by 1970, test the tenet of Virchow-Halsted hypothesis. To remind you, the axillary lymph node is a nidus of cancer, suggesting that the axillary lymph node metastasis was not the primary source for distant spread of breast cancer, and alternate means of dissemination were responsible for poor outcome. NSAP by Fisher. It's enrolled from 1971-1974, 1665 patients, and it's published in 1977. Is modified radical mastectomy equivalent to radical mastectomy by NSAP 1970? Yes, it's equivalent. What about nodes? 40% of axillary lymph node group was positive nodes, therefore 40% without Allen also positive nodes. Yet in the group without axillary lymph node dissection, only 19% developed delayed axillary metastasis and underwent delayed axillary lymph node dissection. Allen or axillary radiation didn't improve the long-term outcome for patients with clinically negative axilla. Yet, despite the result of the NSAP and King of Cambridge, still axillary lymph node dissection was the gold standard for another 20 years. This was for two reasons. In patients with clinically negative breast cancer, failure to treat the axilla with either surgery or radiotherapy could substantially increase the risk of axillary recurrence, some cases of which were uncontrolled and severely impaired quality of life. والسكند وده المين اصلا اللي هو اللي احنا كملنا في الاكسيري فوت سيكشن بعد الانساب اللي هم كانوا ما بيدوش ادجفانت كيموثيرابي اكسبت وذ بوست. فعشان كده الانساب ما عملتش حاجه الا طورت من الراديكال ماستكتومي لموديفايد راديكال ماستكتومي. الانساب O6 is breast conservation local control equivalent to mastectomy. هيجاوبت على السؤال دوت ب yes. Patient with positive node received bifluorouracil malfan, no difference in disease-free survival with distant disease-free survival, move from modified radical mastectomy to breast conservation, but still include element. Okay, here from SAD O6, which end in 84, come the conservative breast surgery. Sentinel node biopsy was first developed by Don Martin for melanoma. And by the way, this patient is my patient, and he has melanoma. It's not for breast. And I do sentinel for melanoma. Okay, it's a male patient, obvious from the hair. Armando Gialano adapted the technique for breast cancer, also using blue dye. Radionuclide dye is most commonly used in the United States, and patent blue dye is the most used in Egypt. NSAP 32 answers this question. Does sentinel lymph node accurately assess and stage axilla? The answer is yes. Only 25 patients have positive node. Goal is to accurately assess the axilla and spare the 75% with node negative from morbidity. And the NSAP shows that no change in disease-free survival and distant disease-free survival. In MANAC study, axillary lymphatic mapping against nodal axillary clearance. Does sentinel lymph node have less morbidity than allant? Of course, yes. Lymphedema is much lower. Sensory loss and tingling or paralysis are much lower. Decreased drain, decreased length of stay, decrease in hospital, of course, decreased time resumption of normal activity. It's obvious. It's very obvious from our practice. It was enrolled from 1999 to 2003, and with 1,031 patients and published in 206. What about Z11 study? Can patients with clinically negative axilla and 1 and 2 positive nodes avoid allant? The answer, yes. Sentinel node only positive node into 3 lymph nodes, axilla nodes specified, not specifically irradiated, no increase in axillary recurrence, no decrease in disease-free survival, no decrease in overall survival. So in Z11, we go for T1, T2, N0 clinically, M0, lumpectomy with a sentinel lymph node, even with 1 or 2 positive nodes, we don't go for allant. What about AMROS trial? AMROS trial is to compare allant with axillary radiation as previously said, and both nearly equal in outcome. There is a steady decrease in axillary lymph node dissection from dissection level 1, 2, and 3 till just lymph node biopsy till now. Axillary management after new adjuvant. Is sentinel lymph node biopsy accurate after new adjuvant? The Z1071 prospective study evaluating accuracy of sentinel lymph node after new adjuvant chemotherapy, as it's obvious, 701 patient, 663 with clinically node axilla, underwent sentinel lymph node biopsy and followed by axillary node section. False negative rate overall was 12.6, which is high, with dual tracer 10.8. False negative rate when clipped node localized, which is dead, to 6.8. Ideally, remove 3 or more sentinel lymph node and dual tracer for lowest false negative rate. From here, we go for TET, which is marking the positive lymph node before new adjuvant chemotherapy. Is sentinel lymph node biopsy alone adequate for N1 disease rendered to N0 with new adjuvant chemotherapy? Memorial Sloan Gathering experience shows that single institute prospective study in T1 to T3 biopsy proved N1 breast cancer turned to N0. No further axillary surgery, 3 or more sentinel lymph node removed, biopsied, not routinely clipped. Clipped node, not localized. Okay. We have only 1 case of axillary recurrence, and this patient refused radiotherapy. Then we go for Alliance. Alliance go for clinically node positive axilla, received the new adjuvant, and sentinel lymph nodes positive. We go for 2 limb, axillary lymph node dissection, and no axillary lymph node dissection, even positive new adjuvant with positive lymph node. Go for only radiation. Okay. Eliminating sentinel lymph node biopsy for staging. Now, imaging become more reliable. It's not reliable yet, but it's becoming more reliable. Ultrasound become more sensitive. Now we have a new method to diagnose axilla like PET mammo. Even I think Dr. Reda go for a study at MRI. Yes. We are now tailoring systemic therapy according to progressive, more sophisticated tools based on tumor biology, oncotype, mammoprint, biological marker grade, ER, PR, HER2, Ki76. Can medical oncologists make treatment decision based on biological marker without complete nodal information? That's the coming step. Can we eliminate breast surgery at all? Can we not do breast surgery? I think they are talking about this in many for interventional radiology. especially in triple negative and HER2 positive patients who receive neoadjuvant and have complete radiological response. They mark the bed of the tumor with clips, and then go for multiple biopsies from the bed of the tumor around the clip, sometimes back, and say that's enough. Breast cancer treatment without surgery. That's what I'm just explaining now. Okay. Current indication of maxillary surgery, central lymph node at the initial procedure to invest cancer in DCIS, especially now we have a large area of DCIS, more than 5 cm. Okay, at the lymph node at the initial procedure, if they have invasive malignancy with nodal positive, mastectomy with node positive, no axillary surgery, but we have now that patient with favorable cancer disease like luminal above 70, T1, we can omit axillary dissection at all. Till now, we are still stick to NCCN. This one is version 3, 2025. We should perform sentinel lymph node should be performed and is preferable method of axillary lymph node staging if the patient is appropriate for sentinel lymph node candidate. If we are going through this. What about enchants? What about we use nowadays in enchants? So in zero patients for upfront surgery, we go for sentinel lymph nodes using beta and blue. Sometimes it's present, sometimes it's not present. So we go for methylene blue. Of course, there's different way injecting beta blue or methylene blue in patients. We go for carbon nanoparticles, ICG. Although ICG, I think it's more experimental than real life work because it needs sophisticated equipment and doesn't give any superiority above other methods. So in zero, we go for sentinel lymph node. What about N1? We still go for Alant. N1 going for upfront surgery. Okay, of course, within an luminal because N1 in triple negative HER2, you go for new adjuvant chemotherapy. N1 received the new adjuvant chemotherapy which is transferred to N0. We have 2 scenarios here. Because we are tertiary hospital, we receive patients from many places. So sometimes the patient doesn't clip the positive axillary. So if patient with N1 receive the new adjuvant, change the N0 without clipping, we still go for sentinel lymph node, but we have to receive 4 lymph node died or died lymph node. At the not 1 and 2 other not died. We have to stick to 4 died lymph node. Okay. And if we receive new adjuvant chemotherapy and still N1, we go for Alant. The problem in this part, if the patient is N1, receive the new adjuvant chemotherapy, the frozen is free from metastasis, and then post-frozen, there is micrometastasis. So we didn't go for completion. We are not going for completion. We go for radiation. Okay. In case of N2, N3, and advanced breast cancer, received the new adjuvant chemotherapy and changed from 2 N0. It is still controlled. We don't have solid data. If N2 to N3 receive new adjuvant chemotherapy and change to N0, go for sentinel or not. And thank you.
Thank you, Dr. Ahmed, for your excellent presentation. Any question from the floor?
Thank you very much, Thank you very much for your presentation. It's very informative and concise to the point. Maybe I would have a comment on the last slide because yesterday I was in a meeting with an Italian oncologist and she was presenting about the early stage breast cancer, and in the criteria of the trial they mentioned lymph nodes, 4 lymph nodes, and she mentioned that they don't have at their center 4 lymph nodes because all of the cases they do for them sentinel lymph node. So they will not sentinel, yes. And they don't go, as you mentioned in the last slide, What about if the patient is N positive or N2? They still go for sentinel lymph node and then don't go for axillary lymph node dissection. So maybe this would be the future. Nobody knows yet. I don't know.
السايز النقطه مهمه جدا. هتقدر تستخدمه اني بيست اوتلايزيشن.
Yeah. Yeah.
more sensitive than mono method we are using it usually. احنا ما عندناش سنتر بنستخدم الديوال ميثود الا مع اوراق حتى مش بيستخدموها بوصف. تمام. انا ما اقدرش ان انا اكون شغال بديتا ميو بس واخد انفوت واحده. وشوف يعني انا في ماي براكتس يعني ان احنا نطلع 4 لينك نود ويطلع الثالثه او الرابعه هي اللي فيها بوستر، مش اللي هي مش الفرق المين التانيين. انا ما اقدرش ان انا اعتمد على على مونو تكنيك اللي احنا شغالين بيه واخد لينك نود واحده. لا خالص.
احنا نامل بقى ان شاء الله ما نبقاش ماشيين الدنيا تتحسن. nowadays yes
برضه حته الديوال تكنيك اللي انا اخش بالراديو اكتيف تريسر مش واضح اللي هي هتبقى كومن المستشفيات في الفتره الجايه. هتبقى بتمشي هوسبيتال زي دمتاش. اما المستشفيات 90% من المستشفيات البرايفت اللي هي بتاخد سيكتور رهيب من العيانين مش هيبقى فيه ديوال
تمام.
النقطه دي بس معلش، هو احنا في سانجالين ميتنج مونيكا مورو بتاعت سلوان كاترينج سنتر بريست كانسر سنتر سالناها السؤال ده، قلنا لها احنا في مصر ما عندناش غير البلو داي. So in cases of N positive disease, turn to N negative disease after neoadjuvant chemotherapy. What to do? We have only the blue dye زي ما انت قلت كده. الإجابة بتاعتها قالت you can stage the axilla if you remove more than 3 lymph nodes. بس عايزة أبين نقطة بس. أيوة يا أحمد، بس مش 4 زور. هي السنتينل هي الزرقاء وجنبها بقى تجيب من جنبها. عمرك ما هتشوف 4 زور. يو انجكت داي اذا سنتينل ليمف نود هي اول واحده هتزرق، بعد 20 دقيقه هتفتح وتشيل من جنبها بقى. يعني لازم تشيل 4 أو 5 if you are using only the blue dye.
انا اجيب اكتر من واحده ضرب يعني اتليست 3 ضرب عشان اكون ساتسفايد.
ما بنشوفش 3 دايت خالص. ما بنشوفش يا احمد 3 دايت. لا يبقى لازم تستنى اكتر من 20 دقيقه. بس استنى بقى شويه.
اشتغل على التيست الاول وبعد كده اخش على التالت هيديني مور لينس.
شكرا دكتور احمد على النايس برزنتيشن. دكتور احمد كده احنا كجروب يعني احنا اي عيانه كلينيكال N1 وخدت نيوادجفنت كيموثيرابي بقت N0 وهنعمل لها سنترال ليمف نود، ده هيبقى كونسنسس عندنا. اصل احنا لسه كنا بندسكاس الموضوع ده عندنا في الميتنج في البريست ميتنج اول امبارح.
حتى مش عامله بريفير اللي هي تكون عامله كليبنج، بس حتى لو مش عامله كليبنج ويريموف اتليست 3 ليمف نود.
بس شرط 3 تمام.
احنا اوريدي في السنتر يكون
ما بنشيلش.
مفيش يعني انا بعتبر ان حتى لو شال واحده او دايت بس ده نوت انف
عشان احنا ما عندناش دول.
بس هي منتهى البساطه هي هتخش دايلما. لو شلت واحده طلع فيها مايكروميتس هتعمل ايه؟ هي تكفي لو 2 أو 3. فلو هو 3 في مايكروميتس كامل.
ايوه كده. يبقى هو كده. احنا الحقيقه ما عندناش دول يبقى
لغايه هذه اللحظه احنا لسه مش عاوزين ناخد فيها قرار كويس يعني N2 أو N3 تشينج تو N0 من غير كليبس.
اعتقد انها حتى انترناشونال جايد لاينز. جايد لاينز كده. لا جايد لاينز هي N1 only.
ولا يقدر عليها حاجه.
Thank you so much. Thank you for the audience. Thank you.
Okay, we come to the end of the session. Thanks all of you and see you inshallah next time.